So you can start now.
Yeah, I'm just presenting the slides. Just a second. Kalpita, please confirm. Visible? Slides are visible in.
Yes, the slides are visible.
Yeah. So good evening, everyone. Dr. Supriya, welcome. I hope your network is not good. Okay, let me start. Good evening, everyone. This is Krishna from Gennova team, and welcome to this KT Live today. First of all, I would like to thanks Dr. Subhash Koval, sir. Thank you very much, sir, for taking your time and joining one of the most important session for Gennova team. And team, we have Dr. Subhash Kaul, very eminent and renowned course director, and also he is the most not required any introduction, and also senior consultant department of neurology, KIMS Hospital, Hyderabad, and also with 40 years of experience in medical field, and also we have 30 years of experience he is having in teaching experience in neurology and trained more than multiple students across India. Thank you, sir. Thank you very much. And also he is awarded multiple awards with State Teacher Award by the Government of Telangana, and also past president in Indian Academy of Neurology, Indian Stroke Association, and Andhra Pradesh Neurology Association, and also fellowship in American Heart Association and Stroke Association, and also in American Academy of Neurology. Thank you so much, sir, for accepting us our invite as a course director. Welcome, sir, once again. Next, we have today our moderator, Dr. Praveen Kumar, sir, and he is also consultant neurologist, KIMS Hospital, Hyderabad, and also he's also participated and presented multiple sessions in conferences like APNSA, Econ, API, Guntur, and Koni Bangalore. And also he is co-author chapter in tropical neurology and also member of IAN ISA 2011. Welcome, sir, today for this moderator session. Thank you very much for joining. And also today we have a speaker, Dr. Manoj Vasireddy. Thank you, sir, for accepting our invite as a speaker today. Thank you very much. And also he is a consultant, international neurologist, History Holistic Hospital, Hyderabad, and also with 9 years of experience across pediatrics, neurology, and advanced stroke care. And also he has specialized in acute ischemic stroke management and also neurointerventional procedures, including mechanical thrombectomy and aneurysm coiling, and also published multiple reviewed papers and presented researches at national international conferences. And also he is expert in diagnosing and managing acute and chronic neurological disorders, including epilepsy, movement disorders, neuromuscular and autoimmune conditions, and also strong advocate in sharing patient-centric care and also public awareness initiatives. And also he is experienced leader in comprehensive stroke services with a commitment to mentoring a clinical excellence towards the patient. Thank you very much, sir, for joining. And I'll just hand over the session to Subhash Kaul, sir, to start, and also post that we will have a case study from Dr. Manoj Vasireddy, sir. Over to you, Subhash Kaul, sir. Thank you so much.
Yeah, thank you, Krishna, for the nice introduction and giving an overview of the whole program.
Thanks.
So I welcome all the attendees, and this is yet another session in which we discuss the cases, which is from the real-time experience of the doctors, because such cases many times are different from what is routinely written in the textbooks. And as Miller Fisher has said, neurologists learn neurology stroke by stroke. So that's how we have been learning neurology, learning stroke since last few years. So with that, I welcome today's case presenter, Dr. Manoj Vasireddy. You just now saw his CV. He's a very active neurologist. So over to you, Dr. Manoj.
Thank you, sir. Good evening. Thank you, Gennova team, for allowing me to present this talk today. Thank you, Subhash Kaul, sir, for taking out time for this. I'll just start by sharing my screen. Yes. I hope my screen and sound are visible. Just someone please reply.
Yes, sir, it is perfect.
Thank you. So I would like to discuss a topic today, that is intra-arterial thrombolysis, which was once a fad in late 90s and early 2000s, but then with the advent of many mechanical thrombectomy devices and so many other protocols, this has lost its relevance. But with two quick cases and discussion, I would like to present this point. It is more to gain clarity from the audience than to present this. So just please be kind with your questions. First, I would like to start with this case. He's a 48-year-old man. He's a smoker. He's a hypertensive. He presented with left hemiparesis, right gaze deviation of 2 hours duration. His NIHS was 14, and quickly, this is his diffusion sequence of his MRI. So there are multiple patchy infarcts in the right MCA territory. And because he had the right gaze and INHS, we took him for the procedure. This is his first angio run of his right ICA. The ICA was occluded, and proximally it seemed like because of this flame-shaped appearance of on the DSA, it seemed like it was a dissection. Then we immediately started the mechanical thrombectomy procedure. We started by aspiration, and after one pass, this was the appearance. And there is a lot of thrombus in the petrocavernous ICA and above, and it was just after one pass recanalized up to that point. Then after two more passes, we were able to reach up to the terminal ICA. There was a lot of thrombus load, and it was forming as and when we aspirate, and thrombus load was continuously forming. Then we gave intraarterial tenecteplase. Because we were just taking n number of passes, thrombus was going on forming, and we were unable to reach the MCA. This is the run after the first dose of intraarterial tenecteplase. Then this is the run after some time. This is a wire. This is the post-procedure CT of the patient. So there was no bleed, and the patient also clinically improved. Just quickly allow me to present one more case before we start the discussion of this topic. This is a case of a 62-year-old female. She had AF with fast ventricular rate. It was not controlled well with medicines. She was a hypertensive and diabetic. She was posted for an electrophysiology study. During the study, which was being done under conscious sedation, the anesthetist noticed that she was not moving on the right side, and there was a left gaze preference. Quickly, we did a CT, and we brought her back to the cath lab table, where the electrophysiology study was already going on. This is our initial angio run. We can see occlusion of the terminal ICA. Just beyond the terminal ICA, the MCA and ACA stumps are occluded. This is her ICA, which was very tortuous, and navigating the instruments was also very difficult at that time. This is after one pass of Solomra technique. We just passed the stent retriever, and partially the MCA opened up, and there is some distal flow, but it was very less. This is again after a pass, not much change. This is a run after the next pass. There was some more recanalization after passing the stent retriever, but then after some time, again, most of it got occluded. This is after we gave intraarterial tenecteplase for the patient. There is some thrombus in the terminal MCA, but most of the MCA and ACA got recanalized after the thrombolysis. These are the other arteries which are grossly normal. This is her post-procedure CT. There are some patchy infarcts in the right hemisphere, but grossly she clinically improved, and Over the next 2 days, neurologically, she was intact, but she developed cardiac failure and multiple cardiac complications. She clinically deteriorated, and after 4 days, she expired due to cardiac illness. So, to discuss this concept, first, let us just get a historical perspective. Earlier in 1999 and 2007, there were 2 trials for intraarterial thrombolysis. They got good recanalization rates. In the PROACT 2 trial, it was 66% recanalization rate with 18% control, but this is not an IVT control. IVT was not yet popular at that time. MELT trial, again, they used urokinase for MCA occlusion. Again, they got good recanalization rates. These 3 trials are post recanalization after mechanical thrombectomy. They mostly tell us about the safety of intraarterial thrombolysis, but it is not a pre-mechanical thrombectomy trial. But for safety, we can refer to these trials, the CHOICE trial, the Angel TNK, and this is a pilot trial in 2024. They establish the safety, and they also give us the doses of alteplase, tenecteplase, and urokinase. Urokinase we don't usually use. Tenecteplase for intraarterial dose is 0.125 mg per kg as per the Angel trial, and alteplase is 0.225 mg per kg of a maximum dose of 22 as per the CHOICE trial. For efficacy, we still have to refer to the PROACT 2 and the MELT trial. They have used 9 mg and they got a 66% recanalization rate. The MELT trial, they were having a positive deflection for the study, but the study was aborted because the guidelines again favored IVT. So based on ethical considerations, that trial was aborted. So in a patient of LVO, intraarterial versus intravenous thrombolysis, the guidelines indicate that all the patients should receive within 4.5 hours intravenous thrombolysis. But in intravenous thrombolysis, it is dependent upon the systemic circulation to deliver the thrombolytic agent to the clot. And usually it is insufficient. For Bhatia's study, we got poor recanalization rates for LVOs. In distal ICA, it was very less than 10%, 5 to 8%. For MCA, it is better, about 30% recanalization rate in LVOs. Basilar, we do not have accurate statistic, but usually recanalization rates are in the same ballpark. This is a meta-analysis of all the intra-arterial thrombolysis studies published in 2021 is a Chinese study. For large vessels, usually the recanalization rates after IVT is 13 to 18%. But if we are able to deliver intra-arterially the thrombolytic agent, it is around 60 to 80%. It is not usually feasible to deliver intra-arterially the thrombolytic agent. And for most people, the guideline usually stand correct that we have to give intravenous thrombolysis within 4.5 hours of the stroke window. Sometimes there are a few cohorts of people where this may still be beneficial. There are 2 cohorts of people for whom specifically this idea may be considered. One, where there is an economic and geographic gap. Let me explain this. Once is the usual case study which we see. The patient comes in a good window period. He comes from the surrounding area to our hospital. We have the setup to perform thrombectomy. We have the necessary people. We have the stroke code in place, and we get the CT and everything. We explain and counsel to the patient that he needs thrombolysis and thrombectomy, and this is the procedure. We explain the risks and benefits of thrombolysis, thrombectomy procedure. They understand everything. They are very good. But then we come to the cost of the procedure. Usually, more than the people who agree for thrombectomy disagree, mostly due to the cost. It's very high. Even though they have some insurance and some coverage and some resources which they can accrue, the initial amount which they have to put up is quite scary. In this situation, maybe intraarterial thrombolysis can be considered for these patients, since we already have the equipment and the setup and the patient is in the hospital. So chemical first strategy, where we can directly take the patient to the cath lab and deliver an intra-arterial dose. And then we can, if the patient is really not able to afford the mechanical thrombectomy procedure, at least this will give a significantly higher benefit than systemic intravenous thrombolysis. Second is the geographical gap, and most of our patients are there in tier 2 and tier 3 cities. The protocol which we follow is, if anyone happens to contact us or our physician emergency ICU friends there, they offer thrombolysis. Usually they come within 4.5 hours. Most of them are in the surrounding regions, and they give the thrombolysis and they shift the patient to a higher center in a nearby city where he can get the thrombectomy procedure. About 3 to 4 hours it takes to reach the nearest urban center where such a facility is available. But in all the tier 2, at least most of the tier 2 and tier 3 cities, cath labs are available. They have cardiologists. They have peripheral interventional radiologists who are able to do procedures like bronchial arteries, varicose veins, peripheral arterial disease. They have the expertise and equipment to navigate the catheters, at least to the large vessel which is occluded. They have the necessary skill to read the CTs, or they can get help from their radiology friends. This is one more subset of patients who may get benefit if they are offered intra-arterial thrombolysis. To perform mechanical thrombectomy and understand the devices, usually it takes time. It is a skill curve. You have to spend some time to learn. But to just navigate the catheter to a particular artery, for people who are already cardiologists or peripheral interventionists, it is very easy. They can navigate the catheter and they can just inject the drug. So for such specific cohorts of people, maybe this is an idea which can be considered, and maybe they might get benefit from intra-arterial thrombolysis. Thank you. This is what I wanted to present. Thank you, sir.
So welcome. Thank you very much, Dr. Manoj. Praveen, welcome.
Yes, sir.
Any comments?
Yeah, wonderful listening to what Dr. Manoj has presented. And as you have rightly said about all of it, we all face the same problem. Initial finances. And recently, in fact, from Mysore, our Indian company has initiated a stent device, and hopefully the cost comes down in the future. And our problem is that our center we are doing, but we have a, I think so, we have more instances of intracranial bleed after the procedures. What is your take on that, Dr. Manoj?
Sir, we have very limited number of cases. We have done it for 5 cases till now. And most of them are when we were not able to recanalize the artery, but the strokes have occurred and the patient has reached us within 1 hour or 2 hours, and we were able to give this drug within 4.5 hours. We do not have the literature or evidence to give it beyond 4.5 hours, especially intra-arterially, because we don't know the safety. But we did not have a bleed in these 5 cases, sir. I am also trying to consult my seniors, mentors, professors, and they told if you can do that, it is not wrong, but we do not have more information on this. Maybe if some institute can take up this study as a pilot trial or something, we can get some information.
You're talking about the intra-arterial tunnectoplase. That is, in fact, in July 2005, there's a big trial which was published, of course, by the Chinese group, Xinghao et al., and they all talked very well about it.
Yes.
मैं क्या बोल रहा हूँ, आपको ब्रांड प्लान का कुछ डाउट से कुछ है ना, इधर क्वेश्चन स्टेप कुछ बना के दे सकते हो, 1-2 क्वेश्चंस इफ यू फील एनीथिंग यू वांट टू आस्क ना, कि
Yeah. Therefore, that trial that was in fact our interventional radiologist also does use it. Therefore, that should not be a problem. But
क्योंकि
otherwise, totally agree. First 4.5 hours, definitely we should go for thrombolysis. After that, thrombectomy. And if the first pass does fail, definitely there is a role of intraarterial procedure, intraarterial thrombolysis with tenecteplase. That should be that should do good. But our only worry is about the is there increased risk for bleed. Call sir, what do you say, sir?
No, see, this is there was a definite role of it in 90s. How we are basically going is by our whole medical practice is driven by trials and guidelines. You know, why are we giving TPA or tenecteplase? Why we are not giving streptokinase? Why we are not giving IV urokinase? IV urokinase, I know some people who have given IV urokinase. We had a doctor here, Parthasarthi Dev. He has given IV urokinase in many patients, and many times it has worked also, because after all, fundamentally, it's a thrombolytic agent and it's cheap. But the way we practice is through textbooks and guidelines, and those depend upon the large-scale trials which are done. So, which Dr. Manoj has just now shown in 90s when I was training in stroke. Provac 2 was very popular at that time, which meant basically intra-arterial, and we have done intra-arterial. We have done intra-arterial in Nizam Institute in good number of patients, and they used to succeed also. In fact, it is only from 2015 onwards when these mechanical thrombectomy came, and it came almost like a storm. And all these associations somehow they have stopped putting intra-arterial in their guidelines. These all Canadian Western guidelines. In fact, the current, if you go by the guidelines, the current support of guidelines is only in addition to the mechanical thrombectomy, which you must have read, that when you do mechanical thrombectomy, you take the whole clot out and still there is some residual clot remaining there. In that, you wash it off with mechanical. That's as far as the guidelines are concerned. So in guidelines, there is no role or no scope of intra-arterial. But I think what Manoj is saying totally different. He's saying that we should use it off-label in an Indian setting where patients are poor and they cannot afford. So I think that's okay. That is a off-label use. But then again, in that off-label use, we'll have to go strictly by legal criteria, which means we'll have to do the PROACT criteria. And I think PROACT criteria was up to how many hours? 6 hours?
Yes, sir. 6 hours. Yes.
Yeah. So up to 6 hours, I think we can always use it in patients, but we can definitely not go beyond 6 hours because, the bleeding is a real chance and we cannot defend it at that time. But up to 6 hours, we can defend because those trials have been done, right? So I think, so what will be the average cost of this 1 lakh?
No, sir. It will be around 70,000 ballpark, 60 to 70,000.
Hmm. Yeah, I think it makes sense, but then we need to have more patience also. We need to have more patience. In institutes, nobody will do this trial. In institutes, nobody will do this trial because I mean, why nobody is doing streptokinase trial? Why nobody is doing urokinase trial? So it will be very difficult because they will say already mechanical is there. Why do you want to go back to that? But I think I see what you are telling. I think we should discuss with our radiologist. Praveen, what do you say?
Yes, sir. Yeah, I think so, sir. But with using of the device, I they will use in addition to the thrombectomy.
No, but
Just
that is not our topic. That we know. We are
yeah,
talking as a substitute for thrombectomy.
yeah, unlikely, sir. Unlikely.
There was a big role of this which was discussed also in the medial vessel, median and terminal MCA. What's called MEVO. And
Yeah,
in MEVO, the stents are not working. Recent trial has also failed of the role of stents in the median diameter vessel. So in those vessels, I think it's helpful. But what Manoj is suggesting is as a complete replacement for. But I see the logic of it. Logic is good. Logic is good. Now that we are not having great results with the stents also, I think this is good. It's at least cheaper. And it has been shown once in PROVAC trial. They've shown that it can be used. In fact, the objection was that there was bleeding with this. There was a higher rate of bleeding with this. But then we are having bleeding with the stents also, disposable stents. So I think Dr. Manoj, you should present it in conferences, in meetings, and all, so that we can have some further discussion and debate on this. Have you had an opportunity of discussing it in some other forum?
No, sir. This is the first time I'm actually presenting this idea, and it is strictly for people who cannot afford mechanical thrombectomy in an urban center. For everyone else, thrombectomy, IVT, the usual guideline stands as it is. We are not arguing with that. Only for people. Eventually, maybe in 2, 3, or 4 years, the government hospitals will give this free of cost, the mechanical thrombectomy, and again, this idea will be not useful to anyone. But in this meantime, not all have the access to get mechanical
So
thrombectomy.
from you must have studied the literature also, obviously, since you are presenting.
Yes.
So from that, what are the advantages of the mechanical thrombectomy over intraarterial tenecteplase?
Sir, intraarterial gives about 66% recanalization rate in large vessels. Mechanical thrombectomy is giving 84% plus what the statistics are saying. So the guideline still stands that we have to offer that. But if somebody is not getting that, maybe this can be considered. Just
And is there any from your survey literature, is there any difference in the rate of bleeding between the two?
They have not
intraarterial
compared.
thrombolysis
They have
versus
not compared. They have not compared head to head anywhere. All those trials have stopped studies when this since 2015 when this thrombectomy picked up interest. Second thing, a situation which is unique in our country is in tier 2 and tier 3 towns we have cardiologists and we have peripheral radiologists who are able to navigate catheters and who are able to do just an injection. It should not be difficult for them.
yeah.
But
Oh,
the
yeah.
guidelines which are done in US and Europe, which we are following, they do not have so many cardiologists in very rural towns and villages. But in India, we have so many, and they have cath labs and they have this expertise to do. So if we can involve them, and if they can offer it at least for patients who are within 4.5 hours, which is very much possible because patients come from within their town or within their villages. So there again, intraarterial may have a role, but again, we have to discuss with others and see if it
I
helps.
remember Dr. Vijaya from Guntur, I think first 10, 15 patients, she did only intraarterial thrombolysis because her husband is a cardiologist. And the moment she would only diagnose a stroke, and he would come, Raghav Sharma would come, and he would she presented in many conferences. It was very much acclaimed. But things changed in 2015 when people suddenly stopped doing, and she also stopped doing. In fact, she used to do, she would not even give intravenous thrombolysis because she would say it's a very blind procedure. Intravenous thrombolysis, if you see, is a very blind procedure. Praveen, it's a very blind procedure. You are blindly giving thrombolysis and hoping that some of it will go to the clot. Actually, it is going to the whole of the body. Can you imagine? IV thrombolysis is going to eye also, to kidneys also, to stomach also, where it's not required. And a very small portion is actually going where it's required, But of course, tenecteplase is better because it is thrombin specific. But still, so what Vijaya would do is that she would say, why to give IV? We'll give intraarterial exactly at the thrombus. But then, the people started, this is not in guidelines, you have to first give IV thrombus. So she stopped doing then this intraarterial and she went to IV and then mechanical. But I completely understand, Manoj, what you are saying is completely correct. To spend 8 lakhs, 7 lakhs, 8 lakhs, and that also not with the assured outcome, and compared to the, one of the hope was and I think that hope has not been, is that this will be a bloodless procedure. There'll be no bleeding with mechanical thrombectomy because you are not giving a chemical. You are just putting a stent and then taking it out. And there'll be no bleeding because you are not giving any thrombolytic agent. I mean, per se here. But I think we are seeing that bleedings are happening even with, So I remember we used to have, I've been part of that urokinase era. So you have not given urokinase, right? You didn't give urokinase was a good agent.
No, sir.
It
Only
was cheap.
tenecteplase we have used. Yes.
Yeah. Urokinase is cheap as dirt, and but good. I think good presentation. Good. Very nice. It's an original idea. I think we should. I'll definitely raise it in future meetings and see what the experts say. So, Praveen, your comments, and I think we don't have any other case today, Praveen.
No, sir. Yeah. Only one comment, sir. As you were talking about that, I got reminded about our senior Dr. Naveen, neurologist at Usmania. In his OPD, he had an acute stroke. This was in 2007, 2008. And he was rushed to KIMS Hospital, where Ravi Verma sir did his intra-arterial thrombolysis. And within 1 week, he again joined back to the hospital.
And now he's in
in
Canada or US. He's now in Canada or US somewhere.
US, sir, US. Yes, sir. Yes, sir. Yes, sir. He's in US. That was a wonderful success, sir. Wonderful success.
It works, sir. It works, and it's cheap. And maybe for few people, this may be the right thing to do. But we have
Great,
to.
great. Yeah. Why not? Why not? Why not? As you tell, when if the patient cannot afford a mechanical thrombectomy, and we feel that for 4.5 hours are gone, you cannot go intravenous thrombolysis. 4.5 to 6. That is the window. If we have to save ourselves, why did you give? This is the way I think so. But at the end, what we are trying to help the patient, isn't it? That's
Yes,
it.
sir. Yes.
Yeah, that's right.
No, and the other thing is that
Okay.
yeah, you are right. From legally point of view, 4.5 to 6 is the narrow window in which we can give it. Yeah.
True, sir.
So Manoj, can it be given to people who have already received IV? On top of it, you can give mechanical or this
We don't
intra-arterial or
have
no?
any literature, sir. We don't have any literature to say that.
Hmm.
We don't have, sir.
Yeah. So finally, we have this. This is a very narrow window. This window is narrower than that of IVTPA.
No,
It
sir.
starts at 4.5 and it ends at 6.
We are withholding systemic and taking directly to cath lab, sir, who are not able to afford MT. We are not giving systemic. Directly, we are giving intra-arterial. That is only for the 5 patients which we have given.
No, but your window is between, see, if you catch them at 4 hours,
Yes.
then you have to give them IV only.
Yeah. Yes, sir.
Or would you still encourage them to?
The Swift Prime trial, sir, where we directly take to MT without giving IVT. And direct MT is not.
No, we are talking of intra-arterial
Yes.
here. We are not talking of mechanical.
Even in 2 or 3 hours, directly, if the patient is not able to afford MT, we give intra-arterial. That we have done only for 1 patient. But that is the idea I'm telling for people. If they can consider that idea, withhold systemic, directly go intra-arterial. 2 hours, 3 hours, 4 hours. If
that will you have to take a lot of consent and a lot of it depends upon the mentality of the patient, because the simple question is why you didn't give standard of care,
Yes.
which is IV.
Yes.
And sometimes people have got other people who, if even one person who is of a litigant type, he can raise this problem.
Yes.
Because definitely a person who will afford this can afford IV also. So up to 4.5 hours, if we don't give IV, so we have to take a very, very informed consent. And then, see, this is the one thing in informed consent I want to tell is that in informed consent, we cannot do anything in informed consent. We have to practice medicine. We have to educate the patient, actually. We have to tell them that this is the trial data, this is this thing, there is this risk. Are you okay with it?
Yes.
So consent also has to be based on the existing literature and the existing. It's not that we can tell him that I want to give you IV aspirin. Are you ready with it? He says, yes, I'm ready with it, give it. We can't do that. That's not allowed.
Yes.
Huh? So therefore, in informed consent also, this is a fundamental thing as a doctor, which we know that one thing is gospel truth in stroke medicine, that up to 4.5 hours, everybody must give IV. So that we cannot deny. Because it's true that 30% of the large artery occlusions also can dissolve by IVT,
Yes.
right? Hello. Hello. Hello.
Yes, sir. Yes,
Sir,
sir. Sir,
Yes.
yeah, the voice was breaking, sir.
Hello.
Anyhow, thank you,
yes.
Dr. Manoj, for showing us this way also. Yeah, I totally agree that in different cases and all, this by taking proper consent, we can. Therefore, as I see it, the window is 4.5 to 6, if we may put it that way.
Yes.
And as Kalsar told, definitely Kalsar takes these ideas and in forums what they say, and can we get back, have a trial project and what, that we should always look in the future. Thank you.
Thank you, sir. Thank you.
Sir, thank you. Sir, there are a
Sir,
couple
any
of questions
Thank
question?
you
from the
very
audience.
much. Thank you, Dr.
Yeah.
Manoj.
Thank you,
Yeah.
sir.
Sir, there are a couple of questions from the audience. I
Yes.
need
Yeah,
more 2 minutes from your side.
please,
Thank you so
please.
much for your time, sir. Sir,
Yeah.
there are number one question is what is the appropriate management for an AOS caused by LVO? What do you suggest? That is number one. And number two, sir, we'll continue. Please respond to this question. So then we'll connect again. One more
I
question.
think you mean AIS.
Acute ischemic stroke. What was
L-
the question? Once more, please.
What is the appropriate management for AAS caused by LVO?
AAS,
Large vessel occlusion.
Acute
AAS,
ischemic.
in AAS. Yes.
large vessel occlusion caused by
In AAS, sir.
What is AAS?
In acute ischemic stroke. In acute ischemic stroke caused by
large
large
vessel.
vessel occlusion.
Yeah,
What is appropriate management?
Yeah, appropriate management is that in the first 4.5 hours, there's no doubt we have to offer IV thrombolysis. After IV thrombolysis, mechanical thrombectomy should be offered. Should be offered in the initial 4.5 hours. There is no doubt. After 4.5 hours, what we look at is that how much is the if the patient comes after 4.5 hours till 24 hours, we have to look at the core, and if there's a mismatch is there, then definitely a mechanical thrombectomy should be done. That is the according to the guidelines. Not offering mechanical thrombectomy possibly may not be accepted at major forums. Therefore, LVO, no, if the patient comes in window, thrombolysis followed by thrombectomy. After 4.5 hours, doing special studies, look at the perfusion and look at the salvageable tissue and definitely proceed with mechanical thrombectomy.
Thank you, sir. Last question. In intra-arterial in this case, and what is the generally prescribed tentriplase or altiplase? What is the most preferred usage?
Manoj
We
sir,
have
please.
2 studies for both tenecteplase and altiplase, sir. We prefer tenecteplase because it is more fibrin specific. Altiplase also can be used.
Okay, sir.
Dr.
Thank you.
Dr. Manoj,
Yes,
in
sir.
which center are you working these days?
Sir, Sri Sri Holistic Hospital, sir. Kondapur and Nizampet.
Okay. But the people who come there must be very affordable one, I guess, no?
They have insurance, sir. About the usual scenario is they have insurance up to 2 lakhs and they can put up some more. Yes. But we still face this dilemma where when we explain the cost of thrombectomy, they just take a lot of time to think. Sometimes they refuse.
But I suggest that you should present this case in some conference. Are you planning to present this in some meeting?
Yes, sir. This is my first presentation. If I can get at least 2 or 3 more cases, then maybe I can make a series and present.
Chalo. Very good. Very nice.
Thank you, sir. Thank you.
Okay.
Yeah, okay.
Thank you very much. Thank you, Dr. Manoj. Thank you,
Thank you,
Praveen.
sir.
And thank you, Team Connect Place, Gennova.
Thank you so much.
Thanks a lot.
Thank you
Thank
very
you.
much, sir. All the panel
Yeah,
members
thank you,
and
Golo.
speaker and Subhash sir. Thank you so much, Dr. Subhash Kul sir and
Thank
Praveen
you
sir
so
and
much,
Manoj sir.
sir.
Thank you so much.
बस मैं
Thank
हूँ घर में आ जाओ ठीक ठीक नो प्रॉब्लम